Good afternoon to everybody. Now is 16:05, so we are ready to start with the webinar after giving the 5 academic minutes of delay as usual. In fact, more people joined meanwhile. So let's start the vascular access webinar part 2, where we will discuss more about the technical issue that can impact the vascular access survival. For the one that did not participate in the part 1, but I hope that everybody could have the possibility to do it. My name is Maria Teresa Parisotto. I'm Chief Nurse Advisor at Fresenius Medical Care. I have more than 30 years of experience on dialysis, and I dedicated the last 8-9 years of my professional life to investigate the vascular access. So it is really a pleasure to share this information with you. Let's start now with the webinar, part 2. Does cannulation technique impact arteriovenosus fistula and graft survival? Technical aspects influencing the vascular access survival. Before really going to the technical aspects, I would like to speak a little bit about the process of decision making, that it is extremely important for the nurses, because we are always in contact with an enormous amount of data, an enormous amount of numbers or data information that we collect during our job. And we have to be able to transform a mass of numbers in a set of intelligible information. How can we do it? First of all, by conveying the numbers to specific statistical analysis capable of providing information. So collecting data, collecting number is not enough. We have then to analyze the numbers. And with the analysis, you can see here we can have a lot of statistical results. But there is another question that we should ask to ourselves. Is this enough to understand how to improve outcomes? Probably not. There is a specific process that we have to do. So from data collection to knowledge, this is the very important word, knowledge, to patient outcome improvement. Let's start with some definition from the Cambridge Dictionary. Data. When we speak about data, what do we mean? Information, especially facts or numbers, to be examined, analyzed, and considered and used to help decision making. The second step is the information. And what is the information? Is a meaningful interpreted data. It means that we have already analyzed the data to get the information. So we have already some statistical results. Is this enough? No, because the most important part is the third one. That means knowledge. And the knowledge is facts, information, and skills acquired by a person through experience or education. So the theoretical or practical understanding of a subject. All this will help us to develop a critical thinking, and a critical thinking is guiding us in the decision making. And this is extremely important because sometimes we can arrive to the point where we have apparently contradicting information, and we have to take a decision. And this decision can be taken only through information, knowledge, critical thinking. Anytime that we have to take a decision for a patient, we should go through this process. Now, let's do a short summary, particularly for the one that maybe were not participating in the part 1 of the webinar. So the summary of the study that we have shown in webinar part 1 was that area cannulation technique, despite being the most commonly used, was inferior to both rope ladder and buttonhole for the maintenance of vascular access functionality. I just want to mention that what in Europe is called area technique, in the United States or North America, let's say, Canada included, they call it one-site itis. So in Europe, we call it area technique. In the United States, in Canada, one-site itis. Then, with regard of the effect of the needle, arterial needle orientation and the bevel direction, the combination of antegrade position, that means the position in the direction of the flow of the arterial needle with the bevel up or down, was significantly associated with better access survival than the retrograde positioning with bevel down. There was an increased risk of access failure for graft versus fistula, proximal versus distal location, right arm versus left arm, and the presence of a venous pressure greater than 150 millimeters of mercury. The topic related to venous pressure was, in the 3 webinars that we have done, creating a lot of discussion. Probably because we were used to consider the most important pressure, the arterial one. In reality, with our study, we show that the venous pressure is having an influence on vascular access survival, while the arterial pressure, we didn't find any indication in this sense. And this is the reason why I want to show 2 additional analyses that we have done. A Kaplan-Meier vascular access survival according to venous pressure. And you can see here that if you have a venous pressure between 150 and 200 milliliters of mercury, or 200, 300 millimeters of mercury, the survival of the vascular access is much lower than if you have a venous pressure between 100 and 150. There is another additional analysis that we have done, and it is the comparison of the blood flow versus venous pressure according to the type of needle used. Because the needle, the dimension of the needle that we are using during the dialysis treatment is having a very important influence on the venous pressure. You can see here, if we use a 14 gauge needle, even with a blood flow above 400 milliliters of mercury, the venous pressure is maintained within acceptable limit, between 100 and 200. You can see here we have 50 patients that were having this type of venous pressure, and here we are speaking about 30 or 25 patients. But if we use, for example, a 16 gauge needle, you can see that already with a blood flow between 351 and 400, we have a large number of patients here. We are speaking about 300 patients with a venous pressure above 200. Not mentioning the use of 17 gauge needle, where you can see that already with a blood flow below 300, we can have a venous pressure quite high, above 200 or within 151, 200. With a 15 gauge needle, that is the most commonly used, we have for sure a better situations till a blood flow between 350 and 400, we have an acceptable value of venous pressure. You can see here we are speaking about 900 patients having a venous pressure between 150 and 200. It's just a lower number of patients with a venous pressure above 200. Because the choice of the needle that you use should not be only related to the anatomical situation of the vascular access of the fistula, but should also take into account the blood flow that you want to use during the treatment. The higher the blood flow, the larger should be the needle that you are using. Now let's go really to the specific part 2 of the webinar and presentation. Here is an in vitro evaluation that Bionic Medicine Technique from Germany was doing to see what happened inside the venous part of the vascular access when the blood is returning, returning to the fistula. If you are using a needle of 17 gauge, so a very small needle, with a QB of 250 milliliters per minute, the blood is returning inside the fistula at a speed of 6.28 meters per second. So quite high speed. And imagine if you increase the QB to 350, the speed is going out to 8.75 meters per second. Different situations is if you use a 15 gauge needle. You can see that with a QB of 250, the speed is much lower, is 4 meters, 0.14. But even with a QB of 350 milliliters per minute, the return speed is 5.8 meters per second, lower than the speed that you have with a 17 gauge needle with a lower QB. It seems a very difficult slide to understand, but in the next one, I will give you an example that will explain exactly the meaning, the specific meaning of these slides. Because of course, what is influencing the venous pressure and the speed of the blood going back to the fistula, it is really the dimension of the needle. And here there is a simple example. I guess that in your life, at least once you have watered your garden. If you do not put any pressure on the tube, what happened? Look, the water is coming out simply and is going immediately on the earth because you are not putting any pressure on the tube. So you have a no pressure, or let's say low pressure and low speed. But what happens if you put pressure on the tube? Can you see? Immediately the pressure is increasing and therefore the speed is increasing. So this is what's happening inside the venous part of the vascular access. If you use a needle that is too small for the amount of blood that should pass through, obviously you have an increase of pressure and an increase of speed. So it is extremely important that we take the right decision on the dimension of the needle, taking into account the blood flow that we want to use. If you want to run a dialysis treatment at a blood flow of 300, 450 milliliters per minute, for sure you cannot use a 16 gauge needle, otherwise you will have a venous pressure of 300. Keep it in mind. Another important fact is the angle of the needle during the treatment. And this is a study that was published in 2013, and it is a computational analysis, that was done in vitro to see the effect, what happened according to the angle of the needle. You can see that if you have a 10-degree angle, you have a very smooth flow inside the venous part of the fistula. If you have an angle of 20 degrees, you can see that you start to have some turbulences. And if you are using an angle of 30 degrees, you have a lot of turbulences inside the vascular access. Then you have shear stress. And then, of course, this can damage the intima of the vessel, and therefore long-term can create problem for the vascular access survival. Another point that is really important is also the depth of the needle during the treatment. You can see here, if you have the bottom depth, the needle that is almost touching the lower wall of the vascular access, look also in this case, you have a lot of turbulences. And of course, this is because the flow is coming out here. It doesn't have so much space to diffuse, so it's hitting the lower wall of the vascular access and then creating turbulences. If you have the needle in the middle, you can see still you have a little bit of turbulences, but for sure better, the situation is better, lower turbulences. And if you are using the top depth, that means the needle is really at the limit, of very near to the upper wall of the vascular access. This is the best situation because you have less turbulences. But of course, here you have another risk, that is the needle dislodgement. And here come back the process of critical thinking, decision making, because then you have to take the decision, what is the lower risk for the patient? To have a lower amount of turbulences or to avoid needle dislodgement. Probably the most important is to avoid needle dislodgement. So you should insert the needle safe enough, but not too much, but safe enough to avoid needle dislodgement. And for sure, you have to fix it properly. But this is a typical decision that the nurses should take, having in the hands more than one option, and then they have to say which one is the best for the patient, which one is less harmful for the patient. Then we go to these slides saying antegrade puncture may be fistula protective. And I have to say that I like this slide very much. Why? I can tell you immediately. Because this was published in 1974. That means 44 years ago. In 1974, Hudson and Shapiro were already saying that the arterial needle should be antegrade. That means in the direction of the blood flow and not retrograde. 44 years ago. Why? This was their explanation. You can see here this intraluminal flow, so it means that the flow of the fistula is going in this direction. You have the needle inserted in this way, so it means that you create a flap that is against the intraluminal flow. So the intraluminal flow tends to maintain the flap open, and then you have the risk to have extraluminal hematoma formation. While if you insert the needle in the antegrade direction, that means in the direction of the intraluminal flow, you can see that the flow per se is closing the flap, so avoiding the formation of extraluminal hematoma. So we could say that there is an increased risk of hematoma formation from retrograde filling, or you can have a tract closure through the force by antegrade puncture. And this is the reason why they are saying that the antegrade puncture may be fistula protective. 44 years ago, do not forget, because still today you have some people in favor of the retrograde puncture of the arterial needle. This is something that you should do if you do not have any other possibility. But if you have the possibility to put it in antegrade, for sure antegrade is the best solution. Now, with these slides, we are analyzing not only the antegrade versus retrograde position of the arterial needle, but also the direction of the bevel. You can see here, if you cannulate the arterial needle in the antegrade direction with bevel up, you can see that the flap is created here in this direction, Then you have the intraluminal flow going in this direction that tend to open or could open the flap. While if you cannulate antegrade direction with bevel down, you can see the flap is created in this direction, so in the direction of the intraluminal flow. So the intraluminal flow is maintaining the flap closed, tight to the needle, thus avoiding any risk of extraluminal hematoma formation. Exactly the opposite is in the retrograde direction of the arterial needle. If you have the arterial needle in the retrograde direction, the flap is created in this way. So the intraluminal flow going here tend or keep it tight to the needle, while if you use the bevel down, you can see that the flap is creating against the intraluminal flow, so you run the risk that the intraluminal flow is opening the flap, thus creating the risk of extraluminal hematoma. So we recommend to use the antegrade direction with bevel down and the retrograde direction with bevel up. To make easier to understand this concept, we created a simple animation. You can see here arterial needle, antegrade direction, bevel up, and look what happened or could happen during the treatment, that the flap detach from the needle, so then you could have red cells going out and creating extraluminal hematoma. While if you cannulate with the bevel down, you can see the flap is creating in this direction, so in the direction of the intraluminal flow. So the intraluminal flow is really keeping the flap tight to the needle, thus avoiding any risk of formation of extraluminal hematoma. Another very important topic is related to blood flow. Still today, we didn't reach a common decision, let's say, consensus, related to the value of the blood flow. Till which limit of the blood flow should we arrive? There are a lot of differences from country to country. There are countries running dialysis treatment with a blood flow of 500, 550. United States, for example, they are frequently doing this and using this value, but also in Europe, some European countries. There are other European countries using 300 or even lower than 300 milliliters per minute. Japan, for example, is famous to use a very low blood flow, 200, 250. Here we have a study that was done in Portugal. Dr. Pedro Ponce was publishing it in 2014, so 4 years ago. And he detected that with a blood flow above 414 milliliters per minute, you have an increase of hazard ratio. So you have an increase of risk for vascular access failure. Somebody could say, yes, but it depends also from the QA. So it depends also from the access flow. If you have a good access flow, you should not have this risk. So probably these patients were not having a good access flow. Well, of course, we were looking, or he was looking and evaluating also the access flow. And you can see that the average access flow of these patients was between 1,000 and 1,200. So let's say a good access flow particularly for a fistula. So the problem was not really coming from the access flow, but probably was coming from the high blood flow per se that could create problem on the vascular access, particularly on the venous side. And we saw it before, for which reason. Imagine if you have you are doing a treatment with a blood flow of 500 or 550 milliliters per minute, and then you have not a total needle dislodgement, but you could have an infiltration. On the contrary, the needle that is going out from the lower part of the vascular access wall because the patient was doing a movement or whatever reason. If you have a blood flow of 500 milliliters per minute, in a minute, you could have an hematoma of 200 milliliters at that speed. So you could have really severe infiltration and severe hematoma. But of course, additional investigation and additional study need to be done to really clarify this topic. So what are our recommendations for an effective vascular access management from the nursing perspective. We recommend the use of rope ladder cannulation technique, and only when there is a limited area for cannulation sites or for potential self-care dialysis patients to choose buttonhole. Why do we recommend rope ladder instead of buttonhole? Because the buttonhole technique need to be performed in a perfect way. With buttonhole, you don't have any margin of error. So either you do it perfectly, or it's really better that you choose the rope ladder cannulation technique. Moreover, particularly in the last years, there are more and more publications coming out showing that there is an increase of infections when you use buttonhole. And not only the infection of the puncture site, but systemic infections. So we really have to be careful. If we want to choose buttonhole, we have to make sure that we use it properly. We have to make sure that we have enough time to perform it. We have to make sure that the hygienic rules are followed 100% and that the track is created properly. So you need expertise. Don't start buttonhole if you don't have expertise. Arterial needle insertion in the antegrade direction, so blood flow direction with the bevel downwards. In the case of arterial needle, retrograde position, because sometimes if you do not have space enough, you have to put the arterial needle in the retrograde position. But then in that case, the bevel should be upwards. Avoid needle rotation, because in the part 1 of the webinar, if you remember, I show a study demonstrating that doing needle rotation, you have an increase by 50 or 58% risk for acute complications development. So really, needle rotation should be avoided. 15 gauge needle are recommended. 14 gauge needle if you really want to run the dialysis treatment at a very high blood flow. Proper needle fixation to avoid dislodgement. Blood flow between 350 and 450. This is our recommendation. Venous pressure around 150 millimeters of mercury. I mean, it's not easy to have such a low venous pressure, particularly if you have a, I don't know, 450 milliliters per minute blood flow. That's why we say around, let's say between, I would say between 150 and 180, 190, below 200 anyhow it should be. Correct hemostasis. This is also a critical point because, you know, when the patient is at the end of the treatment, he wants to run out of the dialysis center to go home. And then you have the driver, you know, that need to pick up the patient to take them home, that they are always in a hurry. And then we do not give a lot importance to the hemostasis. But an incorrect hemostasis is really a risk for the vascular access. So we have to make sure that the patient is giving the right pressure to the vascular access during the hemostasis and for the right time. 3 minutes or 5 minutes of pressure is not enough. We need to stay at least to 8 to 10 minutes. Very important and crucial is the patient education to care for the vascular access. We are frequently, particularly in the last period, speaking about patient empowerment. And the empowerment of the patient is coming from education, is coming from information. Only an educated and informed patient can cooperate with us. So it is really our interest to educate the patient. This is beneficial for the patient and beneficial for the nurses because we have a most cooperative patient. And another very important point is the clinical staff education on vascular access management. We should not take anything for granted. There is always something to learn. Procedures improved. Meanwhile, what we were doing 30 years ago, we detected later that was not the best procedure. So we really have to keep us up to date to make sure that we cannulate and care for the vascular access on the proper way. And now I'm going back to this because I want to show you 2 slides on the importance of training and education. So again, we can say from data collection to knowledge to nursing practices improvement. And the process that we have to do is always the same. We compare the changes in the cannulation technique 2009 versus 2015. The one that participated to the webinar part 1, remember that in 2009 we were cannulating using the rope ladder technique only in 31% of the patients. In 2015, this percentage went up to 56.2%. And you can see that the area technique diminished from 61 to 29.2%. Still a lot to do because the area technique should be abandoned almost completely. But for sure, we can say that diminish it by half was already a great achievement. And look, buttonhole technique from 6.1 to 14.6. The bevel direction, in 2009, we were using the bevel up in 73% of the cases and reduced in 2015 to 34.7 because we increased the use of bevel down. The direction of arterial needle, we were already in 2009 in a good position because it was used in 63% of the cases, but it went up to 75.1%. And of course, the retrograde direction went down. So you can see that the training was having really an impact and an effect. So we improved a lot our cannulation procedures by using a correct and adequate training program. So we should not really underestimate the importance of the training. And because of that, in cooperation with EDTNA, we were producing, and many of you knows it, we were producing 2 vascular access booklets. One is related to fistula, and another one is related to graft. And in these 2 booklets, you can find really a lot of information and recommendation on how to cannulate and how to care for the vascular access. If you want to receive an electronic copy of this booklet, just go to the EDTNA website, you can see here, and you can download the English version of both booklets. The vascular access for fistula, we have it translated in 13 different languages. The one for the graft for the moment is only in English, but we are in the process of translating it in Spanish, Portuguese, Italian quite soon. So this is the end of the presentation. Thank you very much for your attention. And now it's time to ask question.
My question was about the using of 2 different needles. I mean, if we have to reach the goal to keep the venous pressure between 150 and 180, could we use an orange needle for the venous and maybe a green needle for the arterial if the vessel is not good enough for using a 15, also for the arterial one?
I have to tell you that this was a common practice in the past.
I know, I'm old, sorry.
Yeah, no, like me. I mean, it was a common practice in the past. Then we decided not to use it anymore, but there is nothing against it. Why not? Why not?
Okay. Thank you.
Yeah. Welcome. Yeah, there is a question written, not somebody speaking, but writing the question.
The question is, what do you think is the right access flow to use the 15 gauge needle?
To use the 15 gauge needle, also according to our data, you can arrive to 400 milliliters per minute blood flow. I'm not a fan, to be really honest, I can tell you, but this is my opinion. I'm not a fan of the super high blood flow. I do not agree with the one using the blood flow of 550 or even 600 milliliters per minute, because just imagine in the venous part, because really the venous part is the most risk than the arterial part. If you have not a total needle dislodgement, but just, you know, a movement of the needle, a simple small infiltration, the patient is moving and the needle is going out partially, not completely, partially from the vessel wall. If you have a blood flow of 550 milliliters per minute, I mean, in 1 minute, you have maybe 300 or 250 milliliters of blood going out, creating infiltration, hematoma, and any type of problem before you get the alarm from the machine. So I think that we should stay in a blood flow between 350 and 420, 450, but really maximum. But for 15 gauge needle, already 450 is too much. So you should stay below maximum 400.
We have another question. Can you tell me something about the use of short needles?
Short needles, you mean 1.5 or 15 millimeters, because normally we use the 20 millimeters. Well, you can use the short needle only if you have a very superficial vascular access. Because if you have a vascular access that is not superficial, to reach it, you are obliged, you know, to have a 30-degree or more angle. And we saw that the angle is important for the survival of the vascular access, because if you have a too deep angle, you can have a lot of turbulences. So you can use it only if you have a very superficial vascular access.
We have one question.
Yeah.
What is your experience in cannulation with plastic catheter engraft?
Well, this is a very complicated question. Well, complicated not, but I cannot give, let's say, scientific answer to this question, because it is not so commonly used, the plastic cannula to the graft, particularly the graft prepared with the old material. Maybe with a new material with a third layer that is elastic, so you have the hole that is closing immediately, it would be easier. But I can only give my opinion, but not really based on data, because we do not have data on that. Maybe we should do some studies, but for the moment we don't have data. It can be used, particularly if you have the new graft material. You know, the new one, the so-called AcuSeal, you know, the one that is sealing very quickly. If you are using the old graft material, maybe we have to be a little bit more careful.
We have another question. Is it recommendable, or what is your opinion, to use echodoppler previous to the puncture of vascular access?
It can be recommended, but for sure not for all cannulations. For sure, it is recommendable to use the ultrasound with a new fistula, complicated fistula, you know, when you do not know them. But if you have a fistula that you know very well, without complications, without any type of problem, I don't think that it's necessary to use always the ultrasound guided cannulation.
Angela.
Angela, tell me.
Hello, Maria Teresa.
Hello.
Have you any experience with different lengths of the cannulation?
The needle, you mean?
So, the needle, yes, of course, the needle. You told us it's important where the needle is inside, near the vessel or in the middle. So it may be important to use the right length of the needle.
The study that we have done, we were using only 20 millimeters. So again, I can answer based on my opinion. If you have a very superficial fistula, you can use also the 15 millimeters, because then you reach it, you reach the fistula without having a too deep angle, because we should avoid really to have this angle of 20 degree or 30 degree, because we saw in the slides that is creating a lot of turbulences. If you have a deep fistula, very deep, then of course in that case you should use a longer needle, maybe 25 millimeters. If you have a normal, let's say average, like the majority of the fistula, you can reach properly with a needle of 20 millimeters. It depends really where the fistula is located, if it is deep or if it is superficial.
Yeah. Thanks.
Thank you.
Another question. Thank you, Maria. I understand the information about needle size and shear wall stress. Have you studied the needle size of the needle related to the amount of scar tissue damages to the vessel wall? We always assume the larger the needle, the more damage it does, and the higher the risk of pseudoaneurysm.
Pseudoaneurysm. Yes. No, we didn't study specifically this, but since you are mentioning the larger the needle and the more scar tissue or more problem you could have, the clinical expertise or the clinical practice is saying to us, for example, that if you use a 14 gauge needle, you have a longer time, you need much time to stop bleeding, so you have a longer hemostasis time. And not only, the puncture site sometimes didn't heal completely when this following dialysis, when the patient is coming from the following dialysis, because obviously, you know, the larger needle is creating more problem on the skin and therefore on the vessel. We do not know exactly, because to see what happened inside the vessel, we would need special investigation, but you can see what happened to the skin. That is not healing so quickly as if you use a 15 gauge needle. I hope that this is answering your question.
Hi, Maria. How are you? I'm sure you are fine.
Yes.
Thank you for your presentation. Thank you very much. I have a question. What is your experience about the circulation, the bandage after the treatment? Has it influence of the living of the vascular access? And what's about, yeah, we have some problems with fixed bandage after the ending of the treatment, and the patient want to go home very quick, you know, this problem. How is your experience with this?
So if you use a tape, you should never go all around the arm, never.
Yeah.
Because the tape is not elastic.
Yes.
This for sure not. But if you are using an elastic bandage and you don't put it too tight, because always you have to make sure that you feel the thrill and the pulse in the fistula.
Yeah.
And you don't put it too tight, it can be used. But not the tape.
Very good.
Because
and this bandage is this bandage like plastic or something like this that some of the patients are using. You also said that's not the best solution, or it's no solution.
It must be elastic material. If it is not elastic, it cannot be used. It should not be used.
Okay. Thank you very much, Maria.
We have another question. Can you tell us what you think about using silocaine topical anesthetic or EMLA? How about intradermal injection?
To reduce the pain, you mean? To reduce the pain of the puncture? Well, but not only, I mean, there are publications, yes. There are publications discouraging the use of this type of, because they can, particularly if it is a cream, you know, particularly if it is a cream, because you increase the risk of infections. So, but I do not have really personal experience. I can only answer based on few publications where this topic is mentioned, and it is not recommended in the publication that I have read for this reason. In Europe, it's not used so much. It's used much more in the United States. So I guess that you are coming from either US or Canada. But we do not, Canada. It is not recommended because you increase the risk of infection. But of course, also there, we go back to the critical thinking, decision making. If you have a patient that is completely frightened from the needle, you have to do something. You have to make the choice.
Thank you. Another question. Would you be able to explain differences between steel needle and Teflon in terms of AV longevity?
I would like to. But unfortunately, also in this case, there are no studies. Well, it is not true. There are some studies, but with a small number of patients. But anyhow, there are less complications if you use the so-called Teflon needle or plastic cannula. It can be called in both ways. You have less complications because you have less risk of infiltration. You know, the patient can move and you do not risk an infiltration. So you have less miscannulation, less infiltration, less hematoma, and therefore you have reduced risk of vascular access failure. But the experience on the use of cannula, plastic cannula or Teflon needle, they are mainly in Australia, New Zealand, Canada, and Japan. The country with the highest experience on that use is Japan. In Europe, we are just starting it, and this is the reason why we do not have in Europe studies. But there are some studies that I read recently published from somebody from Canada and somebody from Australia demonstrating really that there are less complications with Teflon cannula than with a metal needle. I think that in the long run, we will go in that direction. Because if you look at the needle used in other departments outside dialysis, almost in no one department metal needle are used anymore. They are all using plastic cannula or Teflon catheter, call it as you like. So we hope to have more information also on data coming from Europe. But as I said, here we do not have so much information, but Canada, Australia, New Zealand, yes. And there is a person that I know very well. I don't know if she's connected in this moment, that is called Rosa Marticorena from Canada. She was working in Toronto, and she recently published an article exactly studying, you know, the complications of metal needle versus plastic cannula. It's a very interesting article that I suggest you to read.
We have another other question. I have a problem with fixing a plastic needle. The needles I use do not have wings.
Yeah, well, in fact, this is one of the weak points, I have to say, of the plastic cannula, because they don't have wings. And this is probably also the reason why it requires much more training time to learn also how to cannulate using the plastic cannula compared to a metal needle. I know that the companies are thinking about that, if it is the case to introduce also the cannula with the wings. But for sure, one thing that you have to do if you don't have the wings, you have to cover at least 75% of the surface of the cannula with the tape. You have really to go around the tube, you know, and you have to cover 75% of the surface. And in that case, you are relatively sure that you don't have any type of problem. So if there are no other questions, I think that we can close the webinar. I hope that you enjoy, and I hope that you got information that can help you in your daily life or daily activities, modern life or working life, let's say. And we hope to see you in the future if we organize other webinars, maybe also on different topics. Okay? Thank you very much. Have a nice weekend.